ahead with the next session, I would like to call Dr. Vivek Talukdar. Sir is a professor in pediatrics, Chacha Nehru Bal Chikitsalaya, New Delhi. Dr. Sharmila Mukherjee, professor of pediatrics in Lady Hardinge Medical College and Kalavati Saran Children's Hospital, New Delhi. And Dr. Chaya Sambarya Prasad. Dr. Chaya is a director of ASHA, Center for Autism and Intellectual Developmental Disorders, Chandigarh.
Start कर लेते हैं. So we are going to the next session on carrying autism further, certain interesting issues in management and treatment, diagnosis also. We are going to ahead with the next session. With thanks to Dr. Sefali, we want to start this proceedings of this session. Now, the topics will be more of clinical as well as diagnostic areas. It will involve the clinical and diagnostic areas. The first speaker is probably Dr. P.A. Mohammed Kunju. Dr. Kunju is already well known. He has got a lot of work, and pediatric neurology has become one of the very important figure in neurology chapter of IIP. He will speak on ADHD update, current update. Dr. Kunju. Dr. Kunju will be very particular with time. There are a lot of time constraints.
Okay. So, good evening. Maybe a bit late, good evening. Today, I am going to talk on the certain aspects of attention deficit hyperactivity disorder. Now we all know that after the advent of DSM-5 criteria, the ADHD is included in the neurodevelopmental disorder spectrum. Because earlier, ADHD was considered as the disruptive behavioral disorder in the DSM-4. And in 2013, DSM-5 is considering it as a neurodevelopmental disorder. And I don't have to discuss the clinical features of ADHD to this audience. We know you are all dealing with it. And it is a very big problem for the parents, as you can see in this video where the child has to be chased by the parent always. And they have a problem because they wish to focus, but they can't. They wish to perform, but they can't. And there are millions of them in India as well as abroad. This condition can proceed even to adolescence or adulthood. Because Saroj, a 17-year-old child, was brought to me because of the school truancy. Because he never reaches the school. And he was stealing things, but recently he stole rupees 2,000 and he spent it. And he frequently attacks his mother. And even from the infancy, he was having an incessant crying. And many times he was changed at the school. Though he was very good at maths, otherwise he fared badly in the class. Father, because of his problem, has to return from Gulf, and his sister, who was studying in BSc, all were in tears because of the child. And we know that even our school system, CBSE, state syllabuses, accepts all these problems of children, and there are remedial measures for it. And the lay public, even in Kerala also, we have a lot of science magazines for lay people. In all magazines, every year I write at least 2 or 3 articles because of the request of the editors. And even it is a matter for our cartoonists as well as novelists, way back from Tom Sawyer's naughtiness. And as mentioned, even this era of digital life, we can see that number of cartoons are coming like this. What, you want me to visit your home page to see your homework? And in the 18th century itself, you can see that the story of Fidgety Phil has come, where let us see Phil can be a little gentleman. But ultimately, you see what has happened. He has just pulled out the tablecloth, and ultimately it was a big tragedy where all the utensils, everything has fallen on him. That is the story of the Fidgety Phil. And so we all know the triad of symptoms in ADHD, that is inattention, hyperactivity, and impulsivity. So the management is in taming this triad. So as I have mentioned, the DSM states that the behavior must be developmentally inappropriate, and it must begin before the age of 12 years. There is a slight advancement in the year, and must be present for at least two situations, and at least for 6 months, and must be reported by two independent observers, either by the parents and by the teacher. And it should not be secondary to another disorder. And ADHD has got a lot of impacts if untreated, as in a child, where there can be academic limitations, relationship problem, and as the age advances, the child may have a poor self-esteem, and they are prone to whenever a child comes with a plaster in his hand, I immediately ask the parent, is he very hyperactive? Most of the time the answer will be yes. And as an adolescent, they will be prone to have smoking or other substance abuse. And now we know that it can progress to or present in adulthood also, with a lot of people getting into vehicle accidents, legal difficulties, and changing their occupations very frequently, and having problems in adjusting in the workplace. And there are a lot of comorbidities associated with it, like associated depression, and a very, very common problem, as you can see, either before treatment or after the starting of the treatment. What is this? Yes, this child was on anticonvulsants from a neurologist, but you know that it is not a seizure, but just tics. So this is a very common association also. And before going to the treatment proper, just a few points regarding the pathogenesis, because dopamine hypothesis is the major hypothesis regarding the pathogenesis of the ADHD. And we know that it is the defect in the frontostriatal network. There is a 5 to 10% reduction in the volume of prefrontal cortex and basal ganglia, and this may reflect a decreasing myelination of axons also. In various studies, including the PET data, there is a frontostriatal dysfunction is established, and there is a dysfunction in the norepinephrine dopaminergic pathway. Here the main problem is in the functioning of the prefrontal cortex and the basal ganglia, which is rich in dopamine receptors. So it is the frontostriatal system. Both the posterior dorsal striatum as well as the anterior striatum is implicated in the pathogenesis. Among them, the norepinephrine dopamine pathway, where the pathway that starts from the locus ceruleus to the frontal as well as other cortical areas, and then the mesocortical and the mesolimbic system is also in a disarray, where we can see that the attentional, arousal, and the concentration dysfunctions. The mesolimbic pathway, that is starting from the ventral tegmental area to the nucleus accumbens and the olfactory tubercle is one most important pathway in the reward system. And then that is the pathway that is coming from the ventral tegmental area to the nucleus accumbens. And then the mesocortical pathway, that again starting from the ventral tegmental area towards the prefrontal cortex, which is more important in the cognitive control as well as the executive function of the person. And the other dopaminergic activity, pathways may also be implicated. Similarly, the attentional system, that is the anterior system as well as the posterior system, which mainly starting with the locus ceruleus and going to the pulvinar of the thalamus as well as other areas. So, you have the anterior system, where again, as I have mentioned, the dopaminergic pathway. So there is a dysfunction of these pathways, and there is an imbalance between the neurotransmitters. As we all know, the dopamine transporter dysfunction is well established, and that is being understood by the knockout mice, where the dopamine transporter gene is neutralized. And nowadays, recently there are various other studies, the non-dopamine signaling systems are also being studied, where again a knockout receptor, mice with a substance P receptor and thyroid hormone receptor knockout mice, it was found that the hyperactivity which is insensitive to methylphenidate. And there are other receptors also which are important, like again they have utilized another knockout mice with a nicotine receptor, alpha-2 subunit of acetylcholine transmission. So these are very recent reports also. That means although dopamine regulation is clearly central to the etiology of the ADHD, there is a need to broaden knowledge beyond dopaminergic pathways, explore the role of other transmitter systems, so that we would be able to get better therapeutic modalities. So with considering this background of the pathogenesis, what are the treatment modalities that can be utilized for ADHD? AAP guidelines, which has come way back in 2011, which has not modified much, state that for preschool children between the ages of 4 to 5 years, the first we must try behavioral therapy. And it is said that the parents are the best behavioral therapy, so training to parents is mandatory, and best trial is by the parental behavioral intervention. And if this first-line treatment are not available or insufficient, then stimulant medication with methylphenidate can be tried even at the age of 4 to 5 years. But for elementary school children, they must be treated with a combination of stimulant medication and behavior therapy. Alternatives to the stimulant medications are in order, like atomoxetine, guanfacine, or clonidine. And in adolescents, again, can be treated with medication. And sometimes we may go for a drug holidays also in such patients if they are on drug for a long time. So the aim of the management is in controlling the symptoms, the core symptoms of ADHD. And so we must be trying for a long-term ongoing monitoring of the symptoms and adjustment of medications. And I am giving even drugs to children or adolescents till they complete their professional course. I have a child, or now I cannot say him as a child, even he is doing his MBBS, still he is on, I started way back some 20 years back, and still continuing in methylphenidate. So that means they may have to continue for long. And as mentioned, the ADHD below the age of 5 years, it is the behavioral treatment that is more important. Then if that is not available or it is not effective, we can go for a drug treatment also. In behavioral treatment, we can utilize the modalities by telling the understanding by the clinicians that it is a chronic problem and you must be going for a target outcome in the management. So the clinician should recommend stimulant medications for older children and for adolescents, and behavior therapy as appropriate to improve target outcomes in children with ADHD. And they must treat the coexistence conditions also, and follow-up step must be there in a periodic manner. And there must be a goal setting. The desired goals must be set, because you cannot correct everything in a go. So each problem has to be addressed step by step. And information regarding the ADHD, the current status must be provided to the parents, teachers, as well as to the child. And you start the behavioral therapy in such a manner that you start with rewards as well as consequences. That means reward and punishment treatment. For this behavioral treatment must be based for that. Why do you want to go for a behavioral treatment in a child? Why all of us are behaving in a better manner? All of you are sitting quiet here, listening properly, because you don't want to be a mischief in this society or in this stage. And children want to please their parents and feel good about themselves when their parents is proud of them. So, and usually we try to get positive consequences for doing good things, that is rewards. So everybody needs rewards. We work for getting our salary. Similarly, the child also wants to be a nice person to get good rewards. And then we know that if you misbehave, you get punishment. Similarly, so children also will behave nice manner to avoid the negative consequences that follow an inappropriate behavior. So that means the goal of the behavioral therapy to increase the frequency of a desirable behavior. So the step one of this treatment would be first to go for this special time of 30 minutes per day. So here what you do is simply tune into what the child is doing in an interested and complimentary way. And just tell him that, oh, you have done this good thing like that, and don't comment on any other negative aspect. So this must be a special 30-minute time, and this can be continued for a week or so. And then comes the next step, is using positive reinforcement, where catch the child doing something good at least 5 times a day and point it out. And that means that will give him social rewards. And he is told he will earn a point. And points can be accumulated, just like when we use our credit card. You earn point and then you can redeem it for something. Similarly, the child also can redeem it for various aspects. And third is using the negative consequences to reduce misbehavior. Here again, we can take each negative behavior step-by-step manner. For example, the child has a tendency to talk back, especially to the grandparents, or beating the grandparent. Then take that and tell that this is your problem and you cannot continue doing it. So you tell the child that what are the appropriate behavior. Then one more important thing is that the child must be having some other method of expressing his anger or disagreement with the parents also. And so they must be told what are the privileges they will lose. And they can tell that it may be a timeout, or a losing TV time, or having to go back to the bed early. So this all these can be it can be fixed with loss of pre-specified number of tokens, which we have told earlier. And then classroom management also must be in a similar manner. They must be allowed to sit in front. Minimal distraction must be there, and parents must be and teacher must be coordinating in the management. And at home also, an uncluttered desk at home devoted solely for the schoolwork, because if something is there in the table, they'll be just manipulating that, not concentrating in the textbook. And finally, I'll be telling a few words about the drug treatment also, because again, it depends upon the pharmacokinetics and the pathogenesis, which I have mentioned earlier. Because I told you that in ADHD, there is a deregulated monoamine neurotransmission. So what we have to do is to regulate this monoaminergic transmissions. The drug which is used, one is methylphenidate, which is a dopamine norepinephrine transporter inhibition. By inhibiting the reuptake of dopamine, methylphenidate increases the availability of dopamine in the synaptic cleft, and thus increases the dopamine mainly, and some amount of norepinephrine in the striatum and the prefrontal cortex. The problem with methylphenidate is that it is more active in the striatum than in the prefrontal cortex. Because it is active in the prefrontal, in the striatum, it has got that addictive potency. But we have the new drug, atomoxetine, which acts mainly in the prefrontal cortex and doesn't have any action at the striatal level. That is why it is a non-stimulant, non-addictive drug. And atomoxetine acts by just preventing the reuptake of norepinephrine. So it has got a different mechanism of action when compared to methylphenidate. And as I have mentioned, it has got a hypofrontality when compared to the striatal activity of methylphenidate. So it is a better drug when compared to stimulant as methylphenidate. We can say that the action of atomoxetine is more smart than that of methylphenidate.
Dr. Kunju, it is time to wind up.
Yes,
1
yes,
minute.
Yes, 1 minute. It's only 1 minute. I'll be completing. And other drugs like antidepressants and other drugs like bupropion and clonidine also can be used. Clonidine is again a very good drug if used in a titrating manner. Depression and associated problems also has to be managed. And there are a lot of role for a diet being prescribed. But as of now, we know that there is no clear scientific evidence that ADHD is caused by diet or nutritional problems. And as I have mentioned, all the other conditions to be ruled out before making it. This is a case of Klinefelter syndrome, who was diagnosed having ADHD earlier because nobody has examined his genitalia and undressing him. Okay, tuberous sclerosis, again we know that another condition which can have a problem like that. And partially treated PKU also. So to summarize, it is a neurodevelopmental disorder. And the symptoms must begin before the age of 12 years. And we know that ADHD has got a lot of impact if untreated. And treatment by a combination of stimulant medication and behavioral therapy is more important. And when I was just looking for the
Right, Dr. Kunju, please.
accords, I was a naughty kid, Kapil Dev was telling, and ultimately he gained the World Cup for us. So that means being naughty is good. Only thing is that it must be in a controlled manner. Thank you.
Thank you, Dr. Kunju. So it is time up for you. Thank you, Dr. Kunju, for covering the problem very well, extensively, right from neurobiology to clinical manifestations, physiotherapy, neuropharmacology, and also the recent updates. According to, as ordered by Dr. Sefali, there is hardly any time. We are much more behind schedule. So there will be no question. The question may be taken up at tea time.
Thank you.
Thank you.
Thank you, Dr. Kunju, for that nice update on ADHD. And it was very nice of him to discuss parent training and behavior interventions before he spoke about the pharmacological interventions. That's really important to be understood. Now we call upon our next speaker, respected Dr. Nandini Munkur, Madam, honored to chair this session where Madam is giving a talk. She needs no introduction. She is a very senior developmental pediatrician from Bangalore, has done a lot of research and received many awards and many publications to her credit. Thank you very much for being here, ma'am.
Thank you very much for the organizers for giving me this opportunity. I'm going to talk on learning disability. Okay. Hold on. How does this move? Excuse me. Just move this up. Learning disability is a very common problem in India, and we have a very special needs. Our education system and learning disability requires a special review of this condition. So I will, can you just move this? Why is this not moving? Yeah. Okay, learning disability, a group of heterogeneous disorders. It is a central nervous system dysfunction, and the children I'm going to address going to have an average or above average IQ. They may be having difficulty in reading, writing, or mathematics. It may be familial and heritable. What is we say 5 to 10% of neurobehavioral disorders in school age are supposed to be learning disability. Boys are affected much more, and it is a persistent, prevalent condition. What is a major problem is it's a specific aspect of cognition that is impaired that produces one of its outcome as poor scholastic performance, which is supposed to be memory, executive function, language, and visuospatial disorder. So these are the 4 things. What is not learning disability is what is learning disorder, which can be due to comorbid conditions like mental retardations or children with autism spectrum, ADHD, sensory impairment, and others. So having said this, we have said it is going to be a learning with reading, language, maths, but I'm going to talk to the neurobiology of what happens. These are the 4 prongs which can give rise to an academic difficulty in a child, which is the genetic aspect of it, which is the brain structure and function, the core cognitive process, which goes to learning alphabets and the sounds of alphabets, etc., the behavior, and the environment. Now, this is the framework which results in learning disability. The genetics of learning disability is now being studied very well, but because of lack of time, I'm not going to talk much on the genes and the loci which has been found, but it's very high among children also because of the comorbid condition it has. Dyslexia is what is called the reading disability, most commonly recognized and very, 4 times more common in boys and girls, but the girls who are really dyslexic are supposed to be. Now, this is very amazing. 25%, this is ACER report for India, is the study of the children studied in the government schools across all the states. And this is an alarming report ACER puts out every year. And 2017, they have put out this report that 25% of 14 to 18-year-olds cannot read even basic text in their own language. More than half of them struggle to divide a 3-digit by 1 digit. 53% can read English sentences like, "This is a large house. I like to read." 79% of them cannot know the meaning of this sentence. Overall, 76% of youth after 8 years of schooling lack basic foundation in 3 hours. Is this learning disability? I think the first criteria is people should not be identified as learning disabled unless they had proper instructions in the schools. This is a very, very alarming report, and a lot of us in Bangalore are very concerned and working on this with the schools. So what are the cues for early disability? Actually, it starts a child with a poor language development, you must suspect will this go on to a learning disability. That is one of the earliest cues. The DSM-5 does not say like 2 years of schooling after minimum of 2 years after primary school. All those old definitions are all gone out of the window. We have the newer ones, which is a child can be suspected very, very early. So what is the thing he has? He has an immature vocabulary, and he has a particular difficulty with concept words, near, far. He cannot understand this. He misunderstands multiple meanings of a word. Synonyms are so difficult for them. Poor understanding of classroom instructions. Retains very little information when he is learning. In expressive language, he will substitute, omit words, and he cannot say, instead of saying, this is a bus, he'll say something which we go by. He has described functions of the object rather than the name of the object, immature speaking vocabulary, incomplete sentences. All this from a very young age, you're supposed to be troubling at learning sequencing, days of the week, weeks of the month. You can make this out very, very early. These children may also have a poor motor coordination, can be clumsy, awkward, poor sense of balance. This is called motor planning. Motor planning disorders are in a big way, we are not assessing at all in our country, but it has a great impact to know, will this child have a learning disability? I have to go fast because there's no time. Orientation is confused about time in relationships and poor understanding of spatial, which is very, very often confuses right, left, etc. See, the way they can present with a behavioral problem of concentrating, approaching words in a very disorganized manner. They will not complete tasks. All these are because of the executive function which this child has. So many of them have ADHD, can have a comorbid condition, so it's even worse. So the learning disability, you have 4 types of learning disability, and it depends upon 1 out of every 5 children supposed to have a learning disability. Now, if I were to go with what is the learning disability in dyslexia, they have problem with rapid retrieval of words. They don't have phonological awareness or phonological memory. So if you look into the brain of the dyslexic, if you see the dyslexia brain, you have those the non-impaired don't have the posterior signs where automation and frequency are seen as required. The three aspects to reading: one is learning the words, one is you've got to be automated and you've got to learn it like this is a cat, the cat sat on a mat, for the memory to retain. If you say this is, by the time the child finishes, he does not know. So these are some randomized tests you can do with your mark out the P's and A's for you to quickly find. So the 4 types of learning disability which you can have can give you the prognostic indicators are: if the child has a normal rapid retrieval and normal phonological, he is normal. If he has a normal retrieval and impaired phonological, he may be mild. But if he had impaired retrieval as well as and normal, he is going to be having a mild reading disability. If he has both of them affected, it's going to be a severely affected. So you can, in your own clinic, can do a rapid retrieval test, you can do the phonological test, and you can see the automation and can come to a conclusion how severe this child is going to be in his. So reading is only the tip of the language iceberg, because there's much more behavior of semantics and syntax of language which we are not even addressing. So looking into this is what I said. We are only, very, very few of us just address the phonology, and we are not looking into the deeper aspect of the learning disability. What is important to understand is, till the 2nd grade, we have learning to read. Reading to learn only comes in the 3rd stage. In our schools, we don't emphasize on learning to read because we do by rote skills. Learning to read is the child has to be, that is why when you look into the ACER report, they don't have the foundation for reading. This is alarming for our country. So we have to look, rather than concentrating on learning disability, I would put my money on that 80% of children who are in the government schools to see how to bring out about a better learning skill. So poor comprehension, they have problems in vocabulary, working memory, inferential thinking, finding what is the main idea in what you have read. And these are some of the things you have to do in reading comprehension to come to a diagnosis. So reading will have, besides, will have syntax, semantics, and executive functions. This is a child who wrote with semantic error. He's writing, he knew everything about the cricket match which he was writing. But sentences, the bowler bowled first, the wicket fell, the cricket match started at 9 o'clock. He had no sense of how he is forming this thing. So difficulty in reading is decoding, executive function, language. These are the 3 aspects of learning disability which is very, very important. So then comes the heterogeneous aspect of writing. Writing happens only when you can read and have ideas. We emphasize on writing alphabets and not ideas. So only this morning I was talking about writing A, B, C, D, or how we teach is a very, very different thing. Especially when English is not spoken at home. In many homes, and we have English medium schools in our villages and small towns, these children have considerable problem in their ability to learn and write. So vernacular language, which are phonologically sensitive, is a better way of education, I feel, for children with learning disability, especially in houses where language is not spoken, as English is not spoken as this thing. Executive functions, as I told you, is sitting in one place, focusing, time, organizing time or time management. These are all so very important for these children that for them every day is a nightmare. So for you to diagnose, you have to have a good history. You've got to find out what are the problems, how young it started, what about the parent, do they have other children, do they have history, and examination in your clinic can give you a lot of cue if you just followed the 4 models I gave you. The psychological assessment then goes on to looking into your intelligence test. All these are the various intelligence tests. And we also have the learning battery, which many are used, but I also want to tell you, we also use a very good battery developed by our own educationists called the it's called the learning battery, which is by Roxana from Bombay, curriculum-based assessment, which gives you exactly for the Indian schools as to where this child is functioning. Once you have a child, we have to also look into the behavior checklist, and many of them have anxiety disorders, emotional. Once you have this worked out, you have a comprehensive assessment of a child. The role, then what is the role of the pediatrician in this? Because most of them are psychological and psychological testing, and many of them don't even come to you because they're in school age and they rather go to a school counselor, and if the school counselor does not necessarily think he wants to refer it to your pediatrician. Pediatrician, I think, I want to go to the previous slide. How do I go? Okay. Medical intervention is you've got to look for a medical management. Is there a cause for thyroid disorders get missed? Any of these, depression, psychological, psychiatric management, all these things, the role of the physician is rather limited but pretty crucial in understanding the child. First of all, the most important thing is to tell the parents that this is a brain disorder. Your aspect of your participating depends on your counseling. Telling them that this is a brain disorder and it is not a disorder of where the child is pretending not to learn or he's good at everything else. He's very intelligent. They'll tell you all this and he's making excuses for not learning. This is what. But the primary role which I'm talking about is India is one of the most advanced countries where education is concerned. We have the right to disability bill, we have the right to education bill, we have ratified that every child has a right to education, but on paper, if you look at it, it is even better than the Western world. But we have very, very poor skills of implementing it on the ground. The right to education bill states that every child has to be in the school. And also from a poor socioeconomic group as well as a child with disability. Now, when they go to a normal school with other children, what opportunities are they getting to learn? They're isolated, either gone into a kind of a special room or a reading room, or they have a shadow teacher. This normal school children make fun of them as the dull or the stupid guy who's in my class who needs help all the time. So our integration, putting them into a school is what the government has said. But are we? This is a role of the three-pronged approach, which I think is what I want to emphasize today for this millions of our children in our country, that our role as pediatrician is to ask for social justice. What is a social justice? Telling the neurotypical parent in the school that these children also can learn and they also will be having a place to be in the school. It's a role of our pediatrician then going to school and tell them what is inclusive education about. Inclusive education is not taking a child and putting him in the corner, whether he learns or not, but sees that he has the same opportunity to learn at his level like any other child who is typical in the classroom. For that, what is the school management? Does the school management have a written policy on what will you do? Would you have a curriculum which can be tweaked for these children? Just giving few accommodation skills like giving a scribe when he is old, or doing away with the exemption of a language later on, or giving concession in railways, and all are later. But this child is suffering from the grade 1 or even lower than that grade. So for grade 1, you have to talk about an integrated kind of approach. So that is where I think the crucial role of a pediatrician plays, to go to schools and talk about inclusive education. What does it mean? Why should this child be in every class? How do they have to have a curriculum? I was in Canada and I was so impressed when I went to a preschool. The teacher had every day in a kindergarten school, she had an assistant teacher who was every day a new child with a badge to say that this is the child who will be there in the school. And her job was, there was a Down syndrome child in the class. She went around, her job was to teach her that you have to put these blocks today, and that she was sensitized. We have to sensitize our neurotypical children how to accept this. Do we have the courage to go and introduce the child that today I have so-and-so in the class, he cannot sit in one place, he may have a special chance to move out of every 10 minutes, he's a child with attention deficit, he will have a special paper because he can't write, but he is your friend. So acceptance of this child in the community, acceptance of this, making him learn. The government has even given you an NIOS curriculum. There's open school curriculum where this child can pass at his own level, even go to college and do anything. But as a society, as a community, I want to say, what's the use of talking about one heterogeneous genes, etc.? I think our job is to put this child through a proper education, which is very much possible, to work with all the high-end schools. That's what I'm doing. working with them to develop a curriculum, how
I'd
to
like
accept
to
this
interrupt.
child
Your
into the
time
school.
is almost up.
Thank you very much. That's all I have to say. Thank you.
It was a nice talk.
Thank you, Dr. Nandini. And it's a great message that Dr. Nandini has given to all pediatricians that for children with learning disabilities and other neurodevelopmental disorders, there has to be social as well as a medical model working together. It's not all about medications and interventions at the centers, but we have to go out and reach out to the schools and teachers and the families and help them. Thank you very much.
Thank you, Dr. Nandini. We'll be calling the third speaker, Dr. Asha Chitnis. She is a pediatric physiotherapist and the director of the Vedanta Pediatric Center in Mumbai. She'll be talking about sensory integration, current concepts.
I know I'm the last speaker today, and I'll try to be very brief. I'll just give you what is the take-home message. So I'm going to just, what I'm really going to do in this lecture right now is going to explain you, do we understand what is sensory-based motor dysfunction or understand motor-based dysfunction? If you understand that, how do we blend approaches? I guess everybody knows that your tactile, proprioceptive, and vestibular systems help you understand your body, but it's the vision and the auditory system helps you understand the external world. So children interact, and I think so interaction in the environment is nothing and requires sensory processing. What is sensory integration, which is a small part of sensory processing, is basically organizing sensations from one's own body and helping us interact in the environment. What happens to our kids? We have so much of stimulus, so much of inputs coming into the system. They're so very confused, and that's where they're just basically on a same routine stuff, and hence they show that there is a sensory processing dysfunction. I think behaviors are a great clue that there is a child who has sensory processing dysfunction. If you really understand, this was the recent stuff that came out, we have sensory processing dysfunction or disorder has three main things: a modulation disorder, a sensory-based motor dysfunction, and sensory discrimination disorders. We have been discussing about ADHD, learning disability, and autism. Kids with autism will always have a modulation disorder. Kids with CP and some kids with autism will have a sensory-based dysfunction. And kids who have learning disability will show you problems in discrimination. How do you assess them? Then if you look at this child, he basically has good motor systems. So he has a sensory-based motor dysfunction. And this is a child who shows me a child with cerebral palsy has a motor deficit, but because of her motor deficit, she has sensory dysfunction. Having said that, let's understand what are the problems. The first problem that kids with autism show you are the modulation disorders. If you do not modulate your sensations, not can you register, not can you synthesize sensory information. If you can't synthesize, you can't put things into practice, and that's where they are in their own world. Versus you have someone who has an oversensitivity. They are fussy kids, they have always a flight and fright. Anything can mess them up, a smell, a crowd, a movement, and they can be very self-injurious to themselves. Or on the other side of the spectrum, you have kids who are very under-responsive, who are very, very passive, withdrawn, quiet, they're just in their own la-la land. Or you have someone who can show you a seeking behavior, who has no concept of gravity, they just seek sensations all the time, and show a lot of stereotypy behaviors. Such kids in school initially are labeled as bad or disruptive. And the last thing that the couple of things that you see are some kids, if you touch them, they don't like, they're called tactile defensive. They are the same spectrum. You can see kids who have auditory sensitivity or visual hypersensitivity. Also, there are kids who are basically going to have problems with steps, ramps, stairs, and they are called as kids who have gravitational insecurity. So these are the sensory systems that you keep seeing in different kids. You will understand that what is arousal then? Arousal, all of us, basically helps us to be alert. And why is it important? Because if you do not have the arousal, you can't interact or meet the environmental demands of participation, behavior, emotions, and in society. Look at this child. He absolutely has an over-arousal. He can't attend. He has poor impulse control, limited tolerance, very poor balance of emotions, can't calm himself down, always has mood regulations. One thing you need to understand when you deal with kids who have a sensory processing dysfunction, these 3 pictures tell you, when you are chilled out and you're relaxed, you're like that cat, okay? But you have to understand every sensory impact or input will upregulate you or downregulate you. You as a therapist need to find out what is happening. Or you're going to meet your boyfriend and you're so happy and she's dancing. Versus at the same time, your mother says you can't go and meet him, that's the crying. So we all go through these ups and downs or these modulation problems. It's the sensory system that takes you up or down. It's up to us to find out. So if you really understand the parasympathetic and the sympathetic, it's your parasympathetic that basically puts you down, and it's your sympathetic that really gets you onto an overload. So if you really understand this, look at the same child. He's on an over-arousal. Some sensory systems is upregulated him. This is a child also who's absolutely up, versus the same child, you look at these 2 kids, they're the same, and he's absolutely down-regulated. So a similar or a single child will go from up to down regulation. In your treatments, you need to understand that, because if you can understand that, then you can treat in the moment. Versus once you get him well, he can really process very well. How do we intervene then? Relationships basically organize brain. That is what you need to understand. I think so. You need to have, I'm just going to tell you one more point out here because I have to run fast. When you are treating a child, he's already in not an optimal arousal. So I, as the treating therapist, can't add to their discomfort. I have to be absolutely pay attention to myself and be in the moment and go as the child tells you. Always make their environment very predictable, transitions predictable, structure and routine and sensory diet are very, very important. My teacher always told me, this is a trampoline, she's really jumping. When it works, anything that works is treatment. When it doesn't, it's assessment. This is basically really looking at basically how much, when you're in doubt, deep pressure really helps. Either I am giving it passively or I'm getting it actively. The more active I get deep pressure, the more better the child is going to be, because that's where you get a lot of proprioceptive inputs. Always look at kids. Make in your houses, empower parents to get them either a hammock or a ball or a bean bag, but kind of get them calming boom spaces that help them be there when they are absolutely disrupted or not in their zone. Also give them textures or tactile mats that can help them lie down, feel, that will absolutely help their tactile system. Always remember vestibular system, the saccules give you forward and backward and your utricles give you side to side movements. That little girl is on an air mattress where I'm really working on her vestibular systems and to get her to kind of down regulate, because the other thing that you can do is use your bolster swings to give you a lot of linear stabilized activities. And this is a hammock where I'm going to work, where I can give him an up and down. Once you have worked, ones who seek sensations, basically use a hammock to get them a lot of proprioception. It's a great lot of work for a therapist also to work. You work, then your child works. We both have to be active about it. These are kids who seek. So this is a Lycra swing where you can put him. There are lots of bean bags that you can put inside, or use a rotator tunnel where you can give them movements and they can seek how much of energy they want. They can absolutely get that out. This is an IKEA chair. It's a great chair where you can close it and look at how he works. And the focus improves, the vision improves, and that's what basically you can close it so you can even get your visual hypersensitivity out. If you look at astronaut board, what you're really doing is give them music, use them to turn, and then
this 1 minute is left.
Sure, I'll finish it off. And we'll work for the vision that is done. These are movements that you can really work for. This is a tire swing where you can work on proximal stability. And this is basically really working on a lot of sequencing activities where you can really work on motor coordination. Once having said that, working for flexion against gravity, this is kind of getting both these hands in midline. So these are activities that you plan depending on your goal. This is a kid who has a huge problem with motor learning. Give them that. Look at vision. You have to look at focal vision, look at peripheral vision. These are pinhole glasses that develop focal vision. These are colored glasses that will, on basis of rainbow, that helps you really cut down the use. Prism lenses work for depth perception. If you do flexion, you get convergence. If you do extension, you're going to get work on visual perceptions. Basically, very important to get midline. If you don't have midline, there are problems that you're going to work. Oromotor is very important. Get them to do a lot of breathing exercises. Music is great for them. It really up or down regulates. This is what I let parents do. I have like her a swing, give her a chewy tube and music. She can get prepared and go to school. So if I have to just kind of run through, just these are basic garments that help you to kind of calm and get them extra. Do hippotherapy, move them through space. These are great stools in school because kids who have ADHD or autism just need to move, have bean bags there. So if I have to end my lecture, it's not about what you do and clinically reason, but how do you do it? And at the end, it's a team approach. Respect your sensory systems. Absolutely sensitize teachers and caregivers and educate and empower and support families. Thank you so much.
Thank you so much, Dr. Asha. It was a pleasure listening to you, and the videos were amazing. But I'm sorry, because of the time, we have to wind up.
No, that's okay, I understand. Thank you for letting me
I
speak.
thank my co-chairpersons as well.
Heartiest congratulations to Dr. Shefali Gulati and her team for organizing this awesome conference.
The topics were really fantastic. The speakers were fantastic. I am sure there had been, all these would have invited a lot of hot questions. However, because of the time constraints, we could not do that. We could not allow that. We can have these discussions at tea time. Thank you all.